Thanks. My name's Will Cundy. I'm an orthopaedic surgeon at the Children's Hospital in Adelaide, South Australia. Great to be here today. Sorry I couldn't be there in person. Can you hear me okay?
Yes.
Oh, super. So I'll cover three topics. One is bone pain and sort of an approach to bone pain, and then covering AVN and then osteomyelitis in sickle cell disease. Click along. So as an orthopaedic surgeon, there's three main things we worry about. I treat both children and adults. And in those three patients, we do see AVN or vaso-occlusive conditions. They can be in association with a bone crisis, or they can be a bone infarct. And they can occur either in the medullary canal of the femur or any bone, really. And they can also be around the joints, being juxtacortical. The other thing we worry about is anemia, particularly related to their perioperative risk. And the third thing is patients who present with bone pain that may be either AVN or infection, and particularly focusing on the management on infection with patients with sickle cell. Luckily for us, we don't see children under 6 months typically with bone pain, and dactylitis is often from 6 months of age due to fetal hemoglobin. But from 2 years onwards, we do see kids quite often with bone pain or growing pain. It can be really hard to differentiate what's going on, and often the history tells you what might be the story. We do have a list in our head of things we sort of approach for bone pain for kids. Often it's after trauma, like falling over playing soccer, or it can be a night terror type situation, where they typically complain of pain during the night, but then they're completely normal the next day. We do run through a bit of a sieve of things we worry about with kids with bone pain, things like rheumatological presentations, tumours, Perthes, and sickle cell anemias on the list, but it's quite a way down the list in terms of a common presentation. In terms of how adults present, it's often an insidious onset. Often it's quite a vague story they'll give with bone pain related to sickle cell. It's often around the knee or the thigh or the buttock, and it doesn't really classically present as as an infection or as an AVN. It's often sort of a nagging, sort of niggling pain. About a third of patients will have night pain, and it can be quite a quiet course for their leg, and then they have sudden collapse, and that's when there'll be a real change in their symptoms. Some early signs you might see on examination is some irritability of the hip or some hip stiffness, particularly when you're flexing the hip and internally rotating the hip. You may see some slight reduction in range of motion there, and that's probably because there's some irritation or some synovitis in the joint as a reaction to the AVN process going on. You may also see some waddling of their gait, which is called Trendelenburg, and that may be due to some pain in the hip joint. As a last thing you might see is a leg length discrepancy. So if there's been collapse of one part of the leg, then that leg height will be shorter. Some red flags we worry about as an orthopedic surgeon looking at patients with bone pain or with sickle cell is you worry about asymmetry. So things that are benign are often symmetrical and often self-limiting, but if it's asymmetrical, then we do get worried. Often classic sort of musculoskeletal type pain is nothing to worry about, but if it's out of proportion or it's not behaving like a typical musculoskeletal one that responds with rest and responds with simple anti-inflammatories or simple analgesics, then you do think of other things. If the pain they have is related to a trauma or infection, or there's weight loss or night pain, that can be a red flag as well. A typical workup for patients with bone pain would be usual FBC, UNE, and CRP, and they can be raised or abnormal in both infection or a crisis or an AVN. And in terms of a first-line investigation, always be an X-ray. It's often quite good to get a baseline X-ray, and you compare it to that same X-ray 3 or 6 months later to see if there's any changes. But bearing in mind, you won't see much change on X-ray until about 30% of the bone has been lost. So it can be a later sign. MRIs increasingly becoming the gold standard for workup for patients with possible AVN as a cause for their bone pain. If there's other things going on, you're not too sure, then a bone scan can be helpful to differentiate infection from AVN. And if you're still not sure what the cause is, then often a biopsy or an aspirate will help define things. We use a classification called the FICAT classification, which looks at AVN collapse of the femoral head. Stage 1 is where we can help salvage the joint, stage 1 and stage 2, bearing in mind that stage 1 is often preclinical, so there's no symptoms at all. It's only found on MRI. And then stage 3 and 4, the head's already collapsed, and there's not much we can do to save the head after that situation. In terms of the gold standard MRI, we can see here it's very sensitive and very specific for osteonecrosis. You can see on those top images and the bottom image there, that's a bin of the femoral head, and that white line is like a tide mark of where there's no longer vascular supply to the head. And when the blood supply is re-established, then it takes away the old necrotic bone, and that's then a lot weaker, and then you get head collapse. So not always a bone infarct symptomatic. This patient was an asymptomatic male who's got bone infarcts through the medullary canal of his femurs and tibia. And if it's in the medulla, it can be asymptomatic. If it's around the joint, that's where you get quite significant pain and symptoms. We can also see what's called codfish vertebra in the spine. Again, it can be asymptomatic, and it's this codfish, they describe it, appearance where you get some scalloping of the end plates of the vertebra. If it happens in a child, this is an example of asymmetry where that on the X-ray, I hope you can see the right leg is nice and straight, so the left leg's nice and straight, and the right is quite bent. This is called a fishtail deformity. It's a central growth arrest in a child's knee, and it can be from multiple causes, including trauma, osteomyelitis, but rarely sickle cell disease can cause this as well. And the X-ray on the right is the long-term sort of sequelae of that, where you get quite a deformed femur with this central growth arrest in the middle. Some painful conditions that do end up being a significant pathology are ones near the joint. And this is a patient who presented with sudden medial pain to the knee. And this is a very intense, very painful scenario for patients. They have great difficulty weight bearing. And you can see on the MRI, there's quite a bit of increased signal intensity over the medial femoral condyle. There can be either primary SONC or secondary SONC, which is spontaneous osteonecrosis of the knee. The primary ones, which is just a spontaneous thing, there's no known cause, often do really well with just 6 weeks or 8 weeks of rest, as in no non-weight bearing with crutches. The secondary osteonecrosis do behave differently. This is a typical pattern of osteonecrosis of the knee, and the secondary ones may not follow that typical pattern. They're often quite a bit more aggressive and often result in arthroplasty, so total knee replacement. The reason is because if there's more than 50% of the joint involved, then it's very hard to salvage the joint because of the extensive damage throughout the joint. And these are some of the secondary causes of osteonecrosis, and of course, sickle cell there pops up. We can try to save areas, specifically smaller areas of the knee or the hip, and this is these bone plugs we can use. We basically core out an apple core of bone and a cartilage cap, and you can tamp that in to an area that's been damaged and try and save that area. That is successful in small, discrete, well-contained areas of AVN. But if it's more than 50% of the joint involved, then typically we'll wait for the joint to declare and the patient to be symptomatic enough for a knee replacement. We do worry about putting joints in these bones that have had an AVN process because there's biology there, there's a lack of blood supply, and then there's a revascularization, and the biology of the bone is of concern. We can see here failure of the femoral implant on the right, and then the loosening around the tibial component. If there is weakened bone, then we often use cemented prostheses, particularly around the knee. However, in the hip, we often use uncemented. Another example here of a 32-year-old female who's, you might see some lines through the femoral neck and head through here. They're core drilling lines, so they're sort of scarring from where we've drilled through the top of the femur to try and salvage that area and decompress that area of AVN. And you can see here, this is the MRI showing the right hip here is pre-collapse and the left hip here is about to collapse. So that one is not salvageable, and this one here we can salvage with this core drilling. That one was not salvageable, so went on to hip replacement. There's things we can try before hip replacements. We can try non-weight bearing, statins, clexane, bisphosphonates, hyperaric therapy, and iloprost, so a prostagram analog. None of them really have strong evidence to be able to save the hip. We know that core decompression is probably our best option, but it has to be pre-collapse, and that's what core decompression looks like. There's been a specific paper looking at sickle cell patients with physical therapy alone versus core decompression, and the results from this 2006 Journal of Bone and Joint Surgery paper showed there was no difference. So that's some food for thought that we could manage all these patients non-operatively and not rush to core decompress. In terms of how these hips go in the joint registry, there's a national joint registry that collects all hip replacements in Australia. It's been going on for nearly 2 decades. AVN of the hip comprises about 3% of joint replacements that get put in Australia, and they've got a very good revision rate. It's surprising. It's often quite a challenging hip replacement in these patients. Often the bone and the canal is smaller. The proximal femur is often deformed. The bone can be of quite poor quality, and you have thin sclerotic canals. It can be quite difficult to put a hip replacement in, and we always know these patients have a high risk of infection. We therefore prefer to use fully coated, non-cemented femoral stems, as these do perform better. In terms of this hip replacement happening in a young patient under the age of 30, the 10-year survival is 98%, which I think is excellent for young patients with hip AVN. If the hip AVN or a sickle cell AVN process occurs in a young patient, obviously that's not something we can just rush to put a hip replacement in on. This is an example of a patient with AVN, and you can probably see this hip here is starting to drift out. It's lost containment is the word we use, and to contain the hip, we would do what's called a varising osteotomy to try to encourage the whole of the head to remain in the cup, and that will then help to mold that head and keep that in a spherical shape. So you see here over time that head has collapsed further, and then it's remodeled a few years later to remaining quite spherical. An example of a patient here who remained contained, see the head is still under the cup. It wasn't drifting out like the previous one. And this patient actually was booked for surgery to drill that area. And they had a sickle cell crisis on the day of their surgery, so they were postponed, and eventually did so well with non-operative management and physiotherapy they didn't require drilling. So you can see there's no collapse there, and that seemed to reossify and remodel quite nicely. And that's their final result early this year. In terms of preparing for surgery, we know there's some national standards for patients with sickle cell disease with annual reviews and special sort of vaccinations and prophylaxis in children. We rely upon good communication with the surgeon, the anaesthetist, the haematologist, and the blood transfusion lab to get a good result with any child with sickle cell going to theatre. It may be due to tonsils or splenectomy or a gallbladder, or it could be something completely unrelated. As from an orthopedic point of view, we make sure the patient's first on the list. We ensure good pre-op hydration and avoid a tourniquet. There are some papers that say the tourniquet is fine, but we'd avoid anything that's going to increase risk post-op. We use a bit of a traffic light system in consultation with haematology and anaesthetist about transfusing pre-op. And these are some of our risk stratifications we use to discuss with you about what surgery would entail, expected blood loss, and duration of surgery. Things that can affect the patient specifically in sickle cell post-op is dehydration, hypoxia, acidosis, hypothermia, and pain. When you ask anaesthetists to avoid these 5 things, they say, well, that's what we do with every patient. But I think with sickle cell specifically, we have to be quite careful not to be outside the ranges for those post-op factors. I'll finish on an infection case. This is quite a sad case. A 7-year-old presented from Ghana. They had a boil in their leg from the age of 4, so probably a sinus coming from the femur. It wasn't treated for many years. They eventually moved to England and were found to have a discharging sinus with a femoral fracture. The samples grew salmonella. This child had 4 months of IV antibiotics and multiple surgeries to wash out the leg. You can see in this CT scanogram, there's a femur fracture there through that area of osteomyelitis. And if you look closer up here, the femoral head's not looking too happy on that CT scan. So probably whole femur involvement with the salmonella in this patient with sickle cell. We did try to salvage the leg with multiple operations. You see a frame on the leg to try to correct the deformity and try and heal the fracture. The fracture did heal despite the presence of infection. That head there never recovered, the femoral head. We did try to correct the bow of the femur with what's called 8 plates. It's called guided growth. So you can tether one side of the growth plate to encourage the other side to continue to grow to correct the deformity. That was mildly successful, but it was such a bowed sort of crooked leg that wasn't too much we could do, but it did make the leg a bit straighter. You can see here on the X-ray on the left that the patient has what's called a flexed flexion deformity of the knee, and that hip as well is not looking any better. The end result for this 7-year-old was that 5 years later, they ended up having a 16.5 centimetre leg discrepancy, which is quite significant and very difficult to overcome with major surgery required to lengthen the leg. But you can see these bones here are very gracile, very thin, and with history of infection, you worry about reactivating infection by going in again. The child walked with quite a bad limp, and there wasn't much we could do orthopedically to save it. But the point is that infections, particularly whole bone infection in young patients, is quite devastating. You can see here on this MRI, there's absolutely no hip joint at all, a very flat, shallow cup, and no femoral head. And that's the X-ray early this year. Any questions?
Oh, sorry.
Hi, it's Anthea Grimway, things I just from the Children's in Melbourne. Thank you very much for your talk. I just wanted to ask about comments. The current international guidelines in terms of MRI screening for hips, but we don't screen. And I just wondered if there's any comment on that, given particularly stage 1 disease is sort of preclinical. Is there a subgroup where I'm not sort of strictly screening everyone, but I wonder if as part of that annual review, we need to think about that and whether there's a subgroup where it might be a bit more suspicious in terms of screening for this disease.
It was a little bit echoey. Sorry, I think I got the question about screening or evaluating the preclinical hips and how best to do that. Is that right?
Yeah.
Oh, super.
Yeah.
From my experience, the preclinical, pre-X-ray AVN in the hip is often picked up incidentally. So you'll MRI the affected hip or the painful hip, and then you'll find out that the other hip is also involved. So it's difficult because not every hip pain would be from a preclinical or pre-AVN or a pre-collapse scenario. So it'd be difficult to MRI every hip that was, I don't think it would stand up as a screening tool to assess for preclinical and pre-X-ray AVN changes.
Another follow-up question. When you do a hip replacement in a younger patient, so that 18 or 19-year-old, how long would we expect that joint to last for generally?
Yeah. The latest evidence would suggest there's a 93% chance that it will last 17 years. So it's not far off adult joint replacement results. There's not a specific cohort of sickle cell patients that I can specifically comment on. It's often just called AVN, but young hips perform very well. And the comment there would be that we used to be very worried about doing hip replacements in young patients because the previous generation of hips, they often were told, oh, your hip might last 10 or 15 years and you're best off delaying it to avoid many revisions over your lifetime. We know that hip replacements now perform a lot better. The implants and the quality of the bearings are much improved and they do last a lot longer. And we think that the patient is better off having a good quality of life with a pain-free hip rather than struggling with pain for a long time.
Any more questions in the room or online? Okay, looks like we don't have any questions. Thank you, Dr. Kandi. That was a really great presentation. And now I will
the details about acute and chronic pain because that's already been covered. But from a nursing point of view, assessment is really important when you've got a patient on the ward or in your outpatient clinic or on the phone. Is often the case that a thorough assessment to determine the type of pain, where it is, how it came about, how long has it been going on for, severity of pain, just to get a good overview of what's happening. And that can help determine, particularly if it's on the phone, whether the patient needs to come to hospital, whether they've sort of exhausted their pain management strategies at home and need a little bit more input and escalation of pain relief, for example, especially in the acute situation. And patients know their pain very well, and they know what their triggers are, and they also know what the tell is when the crisis is about to start. So, evaluating, what pain treatment has been effective for them in the past is really important. And things that help them to cope with the pain. Do they find that if they take deep breaths or have a hot pack or anything like that, can help to alleviate it or at least minimize it to some extent. And in this sort of assessment, you can also then sort of get a feel for their perception of their pain and how they feel about it, how it makes them feel, how it's affecting their emotionally and physically. And we still use the Wong-Baker faces rating scale, which is, the scale of little smiley faces to the very unhappy smiley face at the end, to evaluate people's level of pain. Even though that was originally, created with children, it's very effective in adults. We all relate to those kind of facial images and determining, the degree of pain that they might have. So if your patients come into emergency, unfortunately, they don't always get seen promptly. And I kind of think this is probably a lot of ways patients are triaged in the ED by how loudly they're complaining. Unfortunately, we do provide our patients with a card that they can present to the triage nurse explaining that they've got sickle cell disease and recommending that they get prompt treatment and are categorised appropriately and not just dismissed and left sitting in the ED waiting room for 6 hours without treatment. Unfortunately, it doesn't always go down well, and sometimes it's people take notice of it, and other times it's not well utilised. So I do like my patients to contact me if they're coming into ED, so I can sort of help push things along a little bit as well. Pain is a vital sign. So when you're a nursing patient on the ward, it should be concluded with all your other vital signs that you do regularly, your blood pressure, temperature, and so forth. So it's important to, include that, how much pain have they got at the time that you're doing the obs, for example, just to kind of keep a record of how they're going throughout the day. The prompt administration of analgesia and not waiting for someone to be writhing in pain before they actually get to have some treatment is really important. And then assessing the efficacy of that pain relief, has it actually helped? If it hasn't helped within, 30 minutes, you need to escalate to the medical team to either bring in the acute pain service if they haven't been involved, or look at other medication options that might be available just to help control that very distressing acute pain. And we would, in our facility at Royal Melbourne Hospital, we would consider a red cell exchange, particularly if a patient's already on the exchange program. They often come in with pain just before they're due their exchange. So, their sickle levels at their highest, and we can find that by instigating a red cell exchange, you can switch off that sort of painful crisis or painful episode. I'm going to use it from now on more quickly. And we had a case of that recently. A chap came in with shoulder pain and had a Met call in the morning because he was in so much pain, had a red cell exchange in the afternoon, was discharged the following day because it had resolved, which was really good to see. And sometimes for our patients who are not on red cell exchange, we might consider a simple transfusion, particularly if they're showing anemia as well. So management of acute pain is a multimodal approach. Unfortunately, isn't just one tablet will fix all, and so we need to consider lots of different sort of strategies. And we also refer to the analgesic ladder as a way of escalating the pain relief, the analgesia requirements of our patients, depending on their pain level and how much response they're getting from their current treatment. So often in our the inpatient setting, you've got someone coming in with a very acute, severe pain crisis, and we need to use patient-controlled analgesia or pain pumps, which are instigated by the acute pain service. But if they're not at that point, if they're at mild pain rating, then we would consider things like short-term use of non-steroidals like meloxicam or Celebrex. Don't generally use aspirin, but I guess it's a possibility. And we find that Celebrex is particularly good because it can help block that enzyme which is activated during tissue damage and help to switch off some of those pain receptors. Most non-steroidals have an anti-inflammatory effect and an antipyrectic effect, which can be also very helpful in the inpatient setting, but also as an outpatient, it's readily available and people are able to manage this at home. Education around taking these kind of drugs is important because we know that they can cause gastritis and that's also another level of pain they don't need. So nursing education is really important with these kind of medications. And then we do use in the wards opioids, generally oxycodone, a bolus pump. Sometimes this is supported with ketamine. It's not an opioid, but it is used as an adjunctive medication with severe pain episodes. And that can be really helpful just in the short term of trying to get on top of the pain as quickly as possible because, you know, it's very distressing for our patients. There are other things that we do try and encourage people to use, the use of antidepressants, not a huge increase or uptake of that in our patient cohort, but it has been researched and certainly I know the American Society of Haematology do recommend the use of antidepressants sometimes to help as a co-analgesic in managing pain, improving mood, increasing people's quality of life. Anti-anxiety agents such as diazepam can be helpful, and so as well as antispasmodics if they abdominal pain. So using other non-opioid medication. And non-pharmacological pain management is important as well. We don't use cold applications, sorry. We do recommend heat, but we also, encourage patients to consider cognitive behavioural interventions, which they can learn through clinical psychology and also nursing education as well. Things that can help, distraction techniques when it's not a severe acute pain episode to help resolve hopefully pain crisis. And acupuncture and electrical nerve stimulation can be helpful. In chronic pain, it's a little more complicated as we know, and as been described as anything lasting greater than 12 weeks, maybe mild or severe, can come and go and has a very negative impact on a person's quality of life, a lot of emotional toll, a lot of emotional labour with dealing with chronic pain. And that includes things like physical limitations where you're just unable to move around normally and do your normal activities of daily living. And that can also then exacerbate the chronic pain as well because you're getting muscle tightness and joint stiffness and generally adds to that whole situation. And so really good to hear Dr. Kundi talking about physiotherapy because I'm a strong advocate for physiotherapy, as long as it's done safely to help people use their own bodies to help manage their pain, increase their muscle strength, maintain that range of movement in their joints and not have to rely too much on pain relief as much as possible. We also know that stress can lead to muscle tension, increased sensitivity to pain, and we can't take stress out of people's lives, unfortunately, worth a lot of money if I could. So it's just, again, learning how to manage and recognise times of stress and sort of having that extra self-care, I guess, around those kind of episodes, exam time, for example, new jobs, finding a house. And so the principles of management we employ is using a multidisciplinary team and using specialists. So we have a chronic pain team, we also have acute pain service. We have a clinical psychologist that we like to refer people to and who specialises in pain, and she's fantastic. She has a pain physiotherapist that works with her and it often gets involved with patients to help so they can take on some of that exercise and management themselves, and obviously within our haematology specialists as well. So it's important, again, as a community of professionals to help our patients. And it's about setting goals and empowering patients to have self-management and not us dictating, but letting people sort of take control of their own lives and condition. So to that end, we promote shared decision making. I don't think anyone really responds well to being told what to do. I certainly don't. It helps to increase knowledge, greater involvement in their own care, improves adherence to treatment. People understand why they're taking something, more likely to take it than just because we tell them to take it. And also, I guess, managing expectations. Is not always possible to have pain, a person not have pain in their lives, and I think that's important that, you know, that's acknowledged that there's always a degree of pain for some people, and, you know, it's managing and maintaining function and being able to cope with it is important. And we find that by having that sort of shared decision making, we can help reduce decisional conflict. So we're not sort of headbutting with our patients about, you know, what treatment they have and what they don't have, and acknowledges their patient perspectives, which includes their cultural needs as well. I think I missed a slide from a long run, but anyway. So the use of opioids for chronic pain is quite contentious. There isn't very much evidence really supporting its use in long term, and certainly at high doses, which, you know, this 120 milligrams a day is very high. The risk of harm is much greater than the perceived benefit that you might get. And so that's why we find the engagement with pain specialists really important to help evaluate sort of the efficacy of what they're currently on, and sort of discussing the risk versus benefit, and promoting additional strategies as well. As I said before, the clinical psychology involvement is really important. And I guess on nursing is, you know, health promotion and education is a really important part of our role. So particularly around opioid use and pain management, we need to sort of educate regarding the use of harm and potential for misuse, and, you know, dangerous side effects such as respiratory depression need to be discussed. We're talking about the hyperalgesia before, so, you know, opioids create their own problems in many ways, and they do also can cause immune suppression and osteoporosis, impaired hormone function, and increased anxiety and depression. So all of that's like a negative feedback loop, if you like, for trying to resolve pain. So if people have a better understanding of the nature of the pain, again, I guess it's also leads into that not catastrophizing it, you know, normalizing it a little bit in the context of their disease, so they're not too stressed about the fact that they might be getting pain on and off, and really promoting wellness. That's an important role for nurses. Regular exercise, you know, good sleep hygiene, nutrition, hydration, all of those things that we've already discussed in various points today. But also it's important to support patients acknowledge their pain, so they're not being treated as pain drug seeking, which unfortunately still does happen, I think, from time to time, and allowing them to be able to communicate their experience to us so we can help them as much as possible. So that's my talk. Any questions? It's straightforward.
Thank you, that was wonderful. Do you talk about nutrition there? Do you use magnesium supplementation?
A lot of our patients do, yes, absolutely, and they find it beneficial. Hydration and magnesium supplementation can really help with muscle cramping, so that's important. I think advocacy is something I didn't really go into, but I think that's also a very important aspect of the nurse's role, and, you know, we try and get involved. Certainly if I've got a patient on the ward, I'll try and at least attend, maybe not every ward round, but as many as I can. Sorry. Oh, I stopped it, sorry. Just to be involved and to be able to advocate and promote, you know, maybe it's time to now escalate to the pain service. Our team in the ward is pretty good, but if they're on a different ward, sometimes we don't always have them on our haematology ward. It's important to help support the nursing staff on those wards to make sure they understand the need for prompt attention to pain, and yeah.
More questions? I do have one. So one of the last bullet points that you had here was about patients still being able to acknowledge the pain. And how do you balance that against certain restrictions that, you know, someone might be drug seeking, for example?
Yeah.
You know, how best, you know, how can a patient best communicate that? So that,
I think it's really, I mean, I think it's hard for patients to communicate. I think it really comes down to health professionals, educating other health professionals. I mean, I like the idea, someone was saying they did a ED education. It was that doctor, I think, wasn't it, from India, from the US, the Indian doctor from the US, saying that they do training sessions for their ED staff. And I just was messaging Kylie madly saying we should do this. So educating health professionals, but I also do a once a year, I talk to the nurses on our haematology ward, going through what sickle cell is and, you know, what kind of things they need to do and how to look after them when they come onto the ward. So it's really about health professionals telling other health professionals how to do this. I think it's a hard thing for patients to do. And what we also find is that patients who present with pain don't always present with the typical features of pain because they've had it all their lives. So, you know, don't be fooled if the person in the bed is not writhing around in pain. It doesn't mean say they haven't got pain. So kind of that sort of information is really helpful. And that's why I do visit them on the ward, making sure they're being looked after. We've got a good team of nurses there.
I was completely echo what you said about it. There's a lot of that sits with us, these professionals, educating other health professionals around and seriously and recognising that pain is real, pain is real, and pain is what we say it is, when we say it is, and when we say it is. And thinking carefully about how we use that stigma because it's very important. I also what you were saying before about the education program that the students were talking about when they go to
Yeah, I know, because they're so busy as well. I think maybe an online program for us might be a good option, just so that people can go and do in their own time, do a, you know, a learning video or something. I don't know, something we'd like to give some thought to. I think also, you know, we're in a major metropolitan hospital, so it's probably a little bit easier. They see more of these patients, weren't there? It's the rural, regional hospitals that are probably a little more requiring of education as well, where they don't necessarily see many patients coming in with sickle cell, don't have a good understanding of it. So I don't know how we actually reach out to those areas as well. I think, Agnes, you got any ideas?
We'll try. But my question or my comment is on the card that you have for ED presentation. I think we also have something similar with Dr. Greenway. We remember the names from New South Wales. One suggested that we do an alert card and do something like an app, especially for the adolescents. You know, it's difficult to be looking around with the paper that they're using our palm of our hands. So we're trying to get funding to see if we can get that alert card and put it in sort of an app.
That would be great.
My question is, you know how you said things subjective and talking of drug seeking, would it be easy, or maybe you do this already, like in terms of, you know, the high doses of morphine, for example, that one person can tolerate, such that this is already there on the care plan, it's already there on their card, so that if this patient goes into ED, they tell them, my pain score is this, and this is what works for me, then it's easy for the doctors to believe and not just think that they're drug seeking. Is that something that you put on the card or in their care plans?
No, we haven't, but and we've got this electronic record, which we have still learning our way through how to best use. We don't have care plans as such. We do have alerts for, you know, this patient has sickle cell, please contact Haematology, but on the EMR, but we don't. Yeah, I mean, I think there's lots of room for improvement. Absolutely.
Yeah, because I think that would really take away this idea of every nurse or doctor who comes and sees that patient, they'll be thinking, my God, why are they taking these levels of morphine, for example? But that works for them. That works for them to stop that pain. So I think it'd be very easy. They are led. I don't know how to use them, but I don't think it's very. I don't know how, but I think that's something that should be put in the record so that it's very easy for the patient. Because sometimes when you are in pain, it's very difficult to express
verbalize.
Sure. But if the information is already there, they'll know what works for them. They'll know the starting dose to sort of ease the pain.
Yeah, absolutely. I think there's a lot we can still do to help improve the patient experience when they present to ED. It does sometimes rely on whoever they meet when they come in the door, and they're, we all come in with our own baggage, I guess. So, maybe that online training might be a way around it, but we do try and get haematology registrar. I usually give them a heads up the patient's coming in so they can get involved early on and help guide the ED physician, make sure that they are contacting, the appropriate pain team if needed. So, I mean, we try as much as we can. Yeah. Monica.
Thank you, Claire. That was a great presentation. I feel like you were question for each other people. But then more of a comment, just as like disseminating information, I guess I agree. Actually, it comes back to the medical, which I think we're trying to make sure that we're all educated about this. We're from South Australia, we're obviously very, very young in this world, in Australia. And it's taken me many presentations to nursing staff and to various other people to understand that typical scenario where a child has been admitted with pain and the recollection is that anyone was physical pain. And this child was literally not moving in the bed. And it wasn't until I went in and actually lifted her arm up and she started shivering and that became evident to people that pain is experienced in different places. So disseminating information comes back to how much we educate people. And I guess presenting to people absolutely. The other opportunities are I was asked to present to the College of Emergency Medicine, so the national conferences that we're having.
Get them when they're young.
So presented to them, and of course in Adelaide we don't have a lot of conferences. And so they haven't seen all the particular publications, and that was very interesting in that perspective. GPs have college presentations as well, and we tap into conferences along with as we might have all heard today, there are guidelines that have been produced.
Yes, that will go a long way to help.
So I think it comes down to education.
Yeah, absolutely. Yeah.
Okay. Lucky last one.
It's kind of more just I know but just in terms of emergency and then doctors. What about like, for example, when it comes to like ambulance, when it comes to education from there,
Yes.
People with sickle cell, unfortunately, we might not be able to have that access to take ourselves to hospital or have access to the vehicle to get there, and our only option is to have an ambulance. Sometimes, it's so hard for them to see, we share it with what do we do in terms of educating the ambulance, we just get ourselves to get them to hospital.
Yeah, well, I mean, that's a good point, Ken. Yeah, absolutely. Well, we can liaise with the Ambulance Victoria. I mean, I think there's probably a lot of work to be done actually in that whole space. The other problem with ambulance services is that they don't always bring them to us. We would like our patients to come to us so that we can instigate, red cell exchange, for example, if it's needed, and they will take you to the nearest hospital. They won't drive past a hospital to get you to a major one. So trying to get that sort of overcome that.
I mean, where it's not enough, you're not showing me enough. You have to do. I get it, ambulance is important and it's for the top level. There is times when you can't leave it and you have no other option but to get ambulance. Sometimes ambulance, but you have to buy alcohol, but it's where sometimes the education.
Maybe that's where that electronic alert system might be really helpful. Just because everyone has their phones with them, don't they? So I mean, I think yes, that's a really good point that you've made. Thank you.
Any more questions? I feel like this conversation could go on.
It's a big topic.
But I will say, Claire, that was a fantastic presentation. I love the perspective that you brought, and definitely it brings in, different views which were shared in the room, which was really great. I mean, I love what Kristen did, and I remember when I asked you, what are you presenting? You're like, oh no, I don't have to. I don't want to because Kristen covered everything. But this was a great perspective.
All right, thank you.
And I loved hearing what the last speaker just added as from the view of a patient. And because it can be very frustrating for us navigating through the journey, and at times, you feel like you are competing yourself, and it should be clear and evident. And even more frustrating when dealing with young patients because why would my child want to learn? It's only 9 years old. So, clearly she needs it. If she does need, if that's what she needs at that moment. So it was really fantastic. So at this point, we are going to wrap up. I would like to thank everyone, all our wonderful presenters, wonderful panelists. You guys did an excellent job, really great conversations. And in the room as well as online, would like to thank Dr. William Kandi, who is still online. That was a great presentation as well, really enjoyed it. And with that, I'm going to invite Agnes, yes, to wrap up for the day.
Dr. Kandi can stay because we're going to
Yes, please.
a picture before we go.
Okay.
Yeah, sorry, just echoing Natalie's words as well. Thank you so much for always supporting us. But I just thought I come on and thank Dr. Nari Elwood. So this year is now Dr. Nari Elwood's term. Her term is finishing as an ASCA chairperson. So we are planning something before the end of the year, but I thought we just recognize her for the wonderful work that she's been leading us. We've gone through meetings when she's been abroad and she's been able to record us messages. Sometimes I cut off guard, like you are presenting in the next conference without even knowing. But we just wanted to thank you, Dr. Elwood, and we should find another position somewhere. Once you leave, you are an ASCA member forever and ever. And we will be sending through invitations because we are planning something with Dr. Elwood before the end of the year. But again, thank you so much, everyone, for joining us, and we'll see you next year. We are going to announce the month later on, something that's very convenient for all the doctors and the patients in Australia. So again, thank you.